All right, it's about 10 o'clock. We've got a few more people joining us still, so people pop in as things go. Today's presentation is from Terry Foster, RN, and a whole bunch of other stuff from St. Elizabeth. And I will turn the mic over to Terry and thank him for his time, and thanks for everybody for joining us.
Well, thank you. I appreciate it, Tony. And welcome to everybody. I'm here to talk to you today about Munchausen's. I titled this talk, I've had every disease known to mankind dealing with Munchausen syndrome. I've actually done presentations on this for probably more than 30 years. For those of you that don't know me, I've been an ER nurse at St. Elizabeth for 48 years, started working in there actually in 1975, 50 years ago, as a ward clerk in the ER, and then as a nurse in 1977. I've been there ever since, and enjoy it. And I've always found Munchausen's to be just a fascinating kind of topic, and I've actually written a couple articles on it, and then, as I said, spoke on it just because it just never ceases to amaze me, and it's also some of the most fascinating information, but absolutely deranged behaviors and symptoms and everything else. So we'll talk about that. So speaking of that, our first slide is this was a young lady who this was 15 years ago. This occurred where she presented to an emergency department with acid that had allegedly been thrown on her face by a perpetrator in downtown Vancouver, Washington, north of Seattle. And anyway, it was evoked a lot of sympathy and things like that. And here, this was actually 15 years ago, there were not as many security cameras as there are now. And she was actually on camera throwing this acid on her face. She did avoid her eyes, which most of the time, if somebody throws acid on somebody, not that I'm an expert on this, but it's usually going to hit their eyes. And she was very careful to not hit her eyes and presented this way. So when you ask the question, how sick can somebody be? This is your answer right here. And there's several other examples I'll tell you about. I'll go through kind of the clinical presentations and information here. I can guarantee if you've worked in healthcare, EMS, anything like that for any period of time, you have on a regular basis taken care of somebody who has had some degree of Munchausen's, but we'll actually go through some of those, kind of stratify some of the different types of Munchausen's and go over that. And then I have a couple interesting case studies that I'll talk about. And I'd also be very interested in hearing your possible experiences with that as well. So it actually was named after a Baron Karl von Munchausen, who was a German cavalry officer back in the 1700s. And he was a widely traveled teller of tall tales. I'm not sure exactly how he got around or whatever, but obviously this was long before any electronic information or anything like that. But people enjoyed this guy, and he had very colorful, very dramatic, and exaggerated stories. And so that's where they kind of named this after him. And I guess I'm also a person that I think some people think I have some exaggerated stories, but what cracks me up if I ever do any presentations or, some of the stories that I've told or things like that, sometimes people come up to me and say you're making that up. And I look at them and I say, you've never worked in healthcare. If you thought I made that up, when you work in healthcare in a very nice way, nothing surprises you. But anyway, this guy actually was he was modeled in a movie as well about this and stuff. I actually watched the movie for a little bit. It really was pretty bad. I think it was like a 70s flick on a real low budget. So anyway, but that's kind of who this was sort of named after. after and stuff. So we'll go over a couple of these things here. And sometimes these can kind of vacillate between different types. I can't say that somebody will say to you, was it type 1 or 2? It's Munchausen's, but I'll tell you kind of the difference here between the first type and the second. And the Munchausen's by proxy is very, very serious, which is what is done to children or even to someone who is challenged or disabled, who's not able to defend themselves. So when we talk about the first type, this is where people fake an illness and there's nothing actually wrong with them. The second type, which I'll go into, is where people make themselves sick by a variety of ways and become sick. They get their jollies kind of doing that. So we're talking about the first type. The first type is where these patients usually have a very dramatic presentation of their medical complaints and very much attention getting, suggesting a medical emergency. A person with Munchausen's does not quietly enter an emergency department, wait in line, register, go sit down and wait, and then wait to be called back. A person with Munchausen's usually has a dramatic presentation, either in EMS, at their home, probably not at their home, often more a place of business or a restaurant, or where they're getting a show, and they're getting people to kind of see what they're doing. So that's a big thing that they have a need for, is to present that way. Usually not calling a squad at home by themselves. That's not a way they present, or they may kind of fake stuff on their way in. And there literally is no evidence of disease. There may be evidence of many previous hospital experiences, especially diagnostic surgeries, that they'll say, oh, I've had all kinds of abdominal surgery. Well, they were exploratory labs, or they may have had a bronchoscopy or some kind of diagnostic test, not really an actual treatment or curative type surgery or cut downs. They pride themselves in someone not being able to get a line in them. So they eagerly submit to any diagnostic or surgical procedure. Most of us, if somebody talked to us and said, we might have to take you to surgery to see what's going on, or you might have to have a cardiac cath, something like that, most of us would be like, wow, you think so? I don't know. Do I need to get another opinion? Do I need to talk to my family? Do I need to talk to my family doctor? What's this doc like? Trying to kind of get information on. With somebody with Munchausen's, is like, oh yeah, do me, take me, whatever I need to have done, or something like that. They want to have all kinds of tests. They really enjoy that. They are pathological liars. Their stories are very inconsistent, and sometimes you can pick up on that. What, as a nurse, a lot of times what they've told me is something completely they tell the ER physician. And it was like, now hold on just a minute. This is what you said, that kind of stuff. They're evasive, false elaboration on the stories. And these are stories that, as I mentioned, they want to intrigue a listener, and they want to evoke sympathy. And that listener may be somebody who was at the scene, who's like, oh, please help me, that kind of stuff. And they kind of pull those people in. Or it could even be the registration clerk, like somebody sign them in, like, oh, I'm sorry. And they're like, oh yeah, and I've had this and had that and all that kind of stuff. They also will shift their symptom concentration, especially if something's been ruled out. So if somebody says, well, I've got chest pain, awful chest pain, that kind of stuff. So we do a cardiac workup. And so 12 lead lab work, vitals, all that kind of stuff. It's like, well, you know what? You're not having a heart attack. It's not your heart. And they're like, well, no, I know it's more like, and they shift it to like epigastric pain. So now, does it have like a GI component there, or is it something where it's going to be more symptoms and more involved, since that one was ruled out? They don't like to have stuff ruled out from them. These patients often have a fictitious home address. They may be staying at a hotel. They also often have absent family members because the family members are burned out on it, or it's a family member who is clueless as to what's going on. Especially if it's like an elderly parent. An elderly parent's still going to love their kid no matter what, and sometimes they're just not putting it together that their child really has a problem here. And you'll notice a lot of times these people do not have visitors either if they end up being admitted. These patients are very familiar with hospital routines and freely use medical terminology, and some of that terminology may be a little skewed, but they'll be, if you're getting ready to put a line in, and they'll be like, you're going to need a 22 on me. Most patients don't know that, or they'll say like, you just have to get my antecubital or something to where it's like, well, okay, how did they know that? Or again, they'll say, I've had this, a GI cocktail doesn't work, that kind of stuff. The next bullet point, this is a common theme. They usually have some limited medical or nursing background, and this is a little bit scary to me. It might have been a person who was in nursing school and flunked out, or a person who was in an EMT class or paramedic class or something like that, or worked as a nursing assistant or that kind of stuff, who has some medical knowledge. Now, obviously, with the internet today, all that information is handed to them. I took care of these patients long before the internet, but they still often have had a history of like going to libraries, buying medical books, subscribing to medical journals, which is very interesting as well. And these patients also have multiple drug allergies. I mean, if you say, are you allergic to anything? And they say, yes, penicillin, codeine, fibromycin, all drugs that begin with the letter M, anything that goes in your IV, anything made with saline, water, oxygen. I mean, they just have a list of like, truly, and I'm not naming off all the drugs. I mean, sometimes there's like 25, 30 meds that I haven't taken that much medicine in my life. But that's what all they're allergic to, and this person's like 35 years old or something like that. That's kind of a red flag. Sometimes they are aggressive, sometimes unruly, demanding, defiant behavior, especially when they're confronted. There's a saying, you never corner a rat, okay, because they'll come out fighting. And there's a lot of truth to that. And it depends on how that person is handled, which again, I think confrontation needs to be done, with some understanding and some gentleness here, because these people truly mentally ill. But a lot of times when they know somebody's zeroing in on the issue, they may just come out swinging, literally, but also very, very demanding. They may have drug-seeking behaviors. Not always is it narcotics. I took care of a lady one time who absolutely loved GI cocktails. About the grossest thing that you can drink is a GI cocktail with Mylana, xylocaine, and Donatol, I think is what's in it, and they taste awful. And this lady absolutely loved them, and it was like, well, should you really keep giving her those and stuff? And she did, and I remember like a lot of times her coming in, and that's all she wanted. These patients also have a long history of signing out AMA. If they even sign out, they may just leave. And there's kind of no record of that because, again, remember I said they have fictitious information. A little more difficult to do today. It's a lot easier many years ago without showing some ID and tracking, especially with our IT advances that we have. But they may sign out AMA. If you give them the paper to sign, they may say something and what to you, and they often used to be referred to as like hospital hobos. They're a professional patient, something along those lines is what they do. So the most common false illness in women is ovarian cancer. Most common false illness in men is testicular cancer. Women will make up about 80% of your Munchausen patients, both with Munchausen's by proxy as a perpetrator, but also just Munchausen's in general. Men, not as much. But when you think about ovarian CA and testicular CA, they are both difficult to diagnose and confirm. They have slow, insidious onsets. They usually occur in younger people, and it's sad if you know somebody who's had ovarian CA or testicular CA. That it's a sad thing, and a lot of times it can be very invasive by the time it's diagnosed. So they know to kind of say this, and then that's like, oh, okay, because really in the emergency department we can't really prove somebody has this or not very easily. And so that's again something where they're going to kind of pull that person in. So before I talk about the second type, sorry, I just advanced that before I wanted to. With the first type, I'll give you one example we had. This was at Edgewood, probably about 20 years ago, and they respond to all the codes in the house, and they called a code in the admitting department down on the first floor. So I go down there, and there is a girl having a full-blown seizure, girl about probably 25 years old, and non-patient care area. It was actually the first week of July with the newer residents, which is fine. And so somebody brought a crash cart, I think, from pre-admission testing. This girl's actively seizing. We get 100% oxygen on her, and IV therapy responds to the codes. Where there was her mother, this older lady, was standing there, and we were asking her these questions and stuff, and she didn't know. And then as we were trying to get a line in her, she's actively seizing. I said to the mother, because we were going to give her some IV push Valium, I said, is she allergic to any medications? And with that, this girl having a seizure stopped her seizure and said no, and then went right back to seizing. She actually pulled the mask down and said no, and went right back to seizing. And they're like, draw up 5 milligrams of Valium stat. And I'm like, oh hell no. I'm like, hold the phone here, hold the phone. And it was like, first off, she should win an Academy Award, because I swear that was the best fake seizure I have ever seen. I've been doing this a long time, or had been then too. And so we finally got her up to the ER. The whole time she's faking the seizure, and I've said to them, she's not seizing, this kind of stuff. So anyway, but she met all the criteria: dramatic presentation in front of everybody, evoke sympathy. The older lady was not her mother. I assumed it was her mother. She went to church with her, and she asked this older lady, could you take me to the hospital? I need to get some tests and things like that. I've got some kind of illness. I don't remember what she said, if she had said she had ovarian CA then or not, but I mean, check. She did everything, and she ended up signing out AMA. But that classic presentation for what those patients do. So the second type of Munchausen's is where they actually have an acute illness that is self-induced, okay? Not often injuries, it's more an illness, although they can have those injuries as well. So this could even be self-injections of urine, stool, or clotted blood that they either inject IM or IV. And I'll tell you about a real sick one at the end of this that did that. They may also consume obvious toxic substances, like letting food be spoiled and then eat it, drinking known poisons. I don't know if you can still buy syrup of Epicac today. I'm sure somewhere on the internet you can probably get it, but they have been known to even drink syrup of Epicac, which induces vomiting. They may add blood to specimens of their urine or their stool. They really derive pleasure from the attention and the puzzlement of doctors and nurses in their attempt to diagnose and treat. These patients with type 2 love the fact that they may not have formal medical education, and they've stumped people. They love that like people who have advanced education and degrees, aren't picking up on what's going on, and they're researching and they're frustrated and all that. These patients love that. And sometimes that comes out in conversation where they'll be like, yeah, I've been to like 5 doctors and none of them know what's going on with me, and they just keep trying this and they just keep trying that and stuff. And so they just don't know where the source of infection is, and they're almost giddy about it, which is always kind of a red flag for you there. So Munchausen's by proxy is absolutely the most serious and debilitating form, and it's the sickest. It is apparent the caregiver, probably 99% of the time, is the mother who describes elaborate symptoms in a child. And these are things like seizures that nobody else sees, projectile vomiting, things like that. The child is forced into numerous potentially harmful diagnostic procedures. Um, and I'll give you a red flag right here. Somebody with Munchausen absolutely loves social media. They absolutely love posting stuff on Facebook, Instagram, Snapchat, things like that, and they're cryptic. Kind of, they'll be like, heading to the ER with James again. Please pray. And then you see all of these things where they're praying, oh, I hope they find the cause of this, all this stuff. I don't know. I just think if my kid was really sick and I was heading to the ER with them, the last thing I'd think about is putting that crap on Facebook. But especially people who want this attention and want the sympathy and want the drama, they just thrive on all that. They'll do that. They'll be putting that stuff on there all the time. And again, that's another red flag. Not always 100% is that the case, but that's a big red flag. So the nature of the problem, I'll go over a couple studies here. This was one done a long time ago, 1982. 19 cases. That's not a high number here, but that's the ones that you know of. Munchausen is very difficult to study because the actual incidence and prevalence isn't known. You just don't know how many people have this. There's 10 boys, 9 girls. Mean age is 3 years. My granddaughter's 3. I can't imagine something like this being done to a child, but imagine it because it happens. The children's displayed a wide variety of symptoms, usually suggestive of a multi-system disorder. It's not just gastroenteritis. It's gastroenteritis and seizures and fevers and just all these things. It's like, what the heck's going on here? The false symptoms persisted with these kids an average of over a year prior to being diagnosed, the diagnosis being Munchausen's. That they over a year, there's all these tests being done, hospital visits, doctor visits, things like that. Most have been seen by numerous doctors, had been referred from hospital to hospital. One child in this study had been examined by 28 specialists. Now, can you just imagine what that poor kid's life and existence was? In each case, the mother was the source of the fraudulent history and the fabricator of the false illness. The mother was making that crap up. The mother is often the perpetrator, which is the saddest news of all. False histories provided by the moms were impressive in the medical detail. Another red flag, and fabricated symptoms were quite realistic. And again, very dramatic presentations, very, very dramatic stuff that the mom is perpetuating. The methods used were combined very cunning, very dexterity, and quite often with the medical knowledge that the actions, the what was going on along with that medical information, they like the fact that they sort of talk in a medical language to another medical profession. That is something they really, really like a lot. Most of these were, again, had some medical knowledge, which again is scary stuff to me. I think about that. It's like, man, this is bothersome. So a couple of these things were bleeding, usually the result of the mother adding her own blood to a child's vomit, urine, or stool. And there's even been cases where the mother put their own blood in that, or mixed vomit. Sometimes the mother has vomited and mixed it with a child's stool to make it look like they've got like a fistula or something like that going on. Fevers, again, that occur that nobody else sees, that the mother might have dipped that in a hot liquid or rubbed the thermometer, things like that. But also just adding chemicals, things like that, to specimens as they are collected, because admitting these children is difficult a lot of times, and so if they're outpatient follow-ups and things like that, they are the mothers like bringing specimens in and those kind of things. Rashes, again, by stuff they've done to their skin. They've even painted their skin, uh, put friction, rubbed sandpaper on their skin, things like that, put dye on there. And then the neuro symptoms, either giving a child a sedative, an adult dose of medication, Benadryl doses, things like that, which again, you can find those obviously in somebody's blood, drug screen, but when initially you're checking them out, you may not know that they've got that. And then again, the fabrication which leads to unnecessary medical procedures, long and expensive hospital stays, and they kind of love that. So the symptom categories are things like dramatic exaggerations, where kids usually don't have headaches that often, but if they do, it's always a migraine, according to that mom, or false saying that they have seizures. And I'm not talking about, like, sometimes we had maybe a kid that's had a little bit of a fever and sometimes they're shivering for like a few seconds, and the parents like, I think they might have had a seizure, and you have to kind of explain what that shivering is. That's not what I'm talking about. I'm talking about somebody who's making up the fact that they're like, oh, they're having these seizures. Again, they alter, falsify the signs. They have actually taught children what to say about an illness and how to fake a seizure, which is incredible. Dissimulations of allowing a real illness to progress. So a child that has a fever and they're not treating it, a child that's has vomiting and diarrhea and they're still giving them, chili or something like that, because they want to perpetuate that illness. Aggravations, contaminating a laceration that a kid has to promote a wound infection, or sometimes even after a surgical procedure, contaminating that wound so that they get a wound infection. And then there's even been where kids have been injected with contaminated urine or stool or something like that to, again, cause these illnesses. It's just sickening. So 7 of the 19 mothers, interestingly, so that's almost half of them, also were victims of Munchausen syndrome themselves. So again, it is not as much genetic as more as all behavior is learned, and that's kind of passed down through generation. And 2 of the families, the sibling was also involved in fabricating the symptoms. Again, getting another child to collaborate on the story as well. You saw this, didn't you? Yeah, you saw it. See, my kids saw it too. Most carried no diagnostic label and were seen by medical staff as caring and loving. Like, oh, she's a sweet mother. She's very involved, and she wants all these prayers said for her kid. All those things are fine. And it really throws off the legitimate situations where you have a child that's sick, but they're like, no, they're just very involved moms. I don't think that would be the case at all. And there's more to be said about that. It would be sort of naive. This Meadows that did the study to seek a single cause for why somebody does this. And it's a long history of a lot of just incredible mental and psychological damage that person has had. Interestingly, for some, the child's illness brought a closer relationship with their husband, while for others, it was sort of a distraction from a dysfunctional marriage. But if I've got a sick kid, I don't have to deal with that marriage issue and the issues at home that may also involve drug abuse or social things like that. and this is very interesting and very true. Several mothers absolutely thrived on the children's wards. They seem to love being in the hospital, helping others, knowing what's going on with the other patients, bonding in the waiting room, in the lobbies, things like that, and sort of invoking a really close relationship with a new doc, a resident, a nursing student, someone who didn't have maybe that interpersonal stuff down pat to where they just sort of get sucked into this whole thing as well. And they're usually very complimentary of the care that they get for that child because they're like, oh, I don't know what I would have done if you hadn't been here, and thank you. And we're suckers for that. Okay, good. I'm glad you got the good care. I'm glad you got that. But that's something again to it's very manipulative behavior, that they'll say that because then as a professional you're sort of hard pressed to sort of confront that person on what that issue is. So a couple other warning things: an illness that is unexplained, prolonged, and so extraordinary, it really prompts experienced colleagues to say, I've never seen anything like this before. Another red flag. This is so unusual, never ever seen it like this before. Or signs and symptoms that are inappropriate and just don't add up. They don't go along with this as well. Big hallmark: symptoms only occur when the mother is present. And because of that, a lot of times the moms won't leave them, and I'll tell you about that. Normal treatments that we give are ineffective, or they're not tolerated. It's like, well, this usually works, and it doesn't. And that will be a pattern of behavior. Again, these kids also have long, long lists of allergies as well, both to foods, medications, things like that, that you think, this kid's 3 years old. How can they be allergic to 20 different meds? But also, you could have a mother who's very confident, like, oh, yeah, I'm glad they're here. I'm not too worried. He's in a good place. And you sort of think, I would be really worried about that if my kid had been in the hospital 3 times, or excuse me, 10 times, and they're only, pardon me, 3 years old. So, as I mentioned before, the first bullet point: mothers are constantly with their child and they won't leave them, even for brief periods of time, to go down and smoke, to go down and get a cup of coffee, to use the restroom, whatever. They don't want to leave their child, and there's a reason for that. Um, the second one is very frightening: families where there has been an unexplained infant death has occurred, or there's many people in this family who are sick. And it's very disturbing to me when you have a mother who almost is proud of the fact that they've lost 2 children, or that they lost a child from SIDS or something like that. It's like most people don't even mention that, but it's almost like a badge for them. And I'm careful how I say that, but I've seen that happen, and it stops your heart. The symptoms of a very rare disorder, things that you normally don't see as a nurse, or as a medic or something like that. You see this, especially if there's more than one. Seizures that don't respond to being on medications. And again, we can draw drug levels to see if they've got a therapeutic dose. And often, because they want that child to seize, they will not medicate that child. So again, it takes a while to sort of draw those labs and things like that. So when we initially see them, both in the EMS and in the emergency department, we don't really know. But again, if this child doesn't have a therapeutic blood level of an anticonvulsant, and they're having a seizure, obviously that's a priority that we take care of right there. Um, so a lot of times these are signs that kind of warrant being a little more watchful. So many of them are associated with other health related factors. So trying to sort out what is normal, what is not here, can be very difficult. So the diagnostic hallmark here is dramatic improvement of the child when they are removed from the suspected caregiver. So it is the good news and the bad news. And when the mother is removed and that child dramatically improves, the thing is that child um, that child can never be alone with that mother again, if at all possible, because especially if they've lost that control, once they get that child again, they're many times will perpetuate that behavior again. So it's sad. It's just incredibly sad to me. So this was a situation 30 years ago. This was actually before security cameras were used at all in hospitals. And this was a situation where at Cincinnati Children's, there was a mother that had her child brought. They were from Florida and came here because she had this intractable vomiting. And this poor little girl, I think, was like 5 years old and had some incredibly low body weight, osteoporosis, things like that from malnutrition and stuff, and ended up having a G tube because of this intractable vomiting. And they brought them up here, and the story is, and I don't have all the facts right in front of me, but the physician petitioned a judge to for them to be able to videotape this mother, and of course she didn't know it. And the mother was seen injecting syrup of Epicac into this child's G tube in her hospital room, and this is where she was doing it once there. And so they had to remove the mom, put her in jail, and like within, I don't know, 2 days, this little girl was like drinking milkshakes and eating pizzas and things like that. And so, I mean, obviously, she's more like a 35-year-old adult today, but just sad, just sick as sick can be. But thank God, this physician had, the knowledge and the intuition that like something's wrong here, and they proved it on camera. And it wasn't just one time that she did it; it was like several times while she was there in the hospital that she put Epicac in the G tube. And also, and this is before the internet, she had ordered like a shipment of syrup of Epicac to her house. Somehow they were able to determine that as well. So she was convicted. I know she went to jail. I don't know the outcome of that. Now it's probably some Dateline episode or something. So um, a lot of times these kids going through this are mentally ill themselves because just of such a dysfunctional mother-child relationship, significant adjustment problems, and they, for them to come out of this and not have some severe psychological trauma or PTSD is very, very rare, and understandably so. So if the child is returned to the family and survived, there's no convincing case in the literature that demonstrates successful treatment, because and I'll talk about some of the options there, but I mean, you're talking some intense psychotherapy for that child. The incidence and prevalence of Munchausen's, nobody knows, just because there's no way to track this or monitor this as well. Many, many physicians are very, very skittish about putting the diagnosis of Munchausen's down, because then is there a potential legal problem with that at all to really kind of diagnose that, or put that in writing? They may have felt that, but not the case. There's a lot of stuff written about it. There's been movies about it, things like that. These have been around for quite a while, and again, they're both they're it's just very sick information. And there's some of these where there actually has been some stories, some online um, documentaries and things like that about Munchausen's, and some very legendary cases regarding this as well. So it's not clear where it came from, what started it. It's thought to be that this the mother has some kind of early infantile or childhood negative experiences that cause them to have this need for attention and sympathy and things like that. People don't really know. In a nice way, I don't really care what caused it. It's just we need to pick up on this, especially if it's by proxy. So a couple things, just strategies for treatment. First off, in our short encounters with our patients, both in EMS and in the emergency department, they tend to be brief encounters. Although they may be frequent, they can tend to be brief. Um, there, you want to first and foremost rule out any real disorders, and that can be really difficult. Like, you have to err in favor of the patient, so make the correct diagnosis, give the patient the benefit of the doubt. We will deal with the psychological later, if at all. In the back of a squad, um, in the emergency department, dealing with the psychological aspects of illness is very, very difficult, just in our environment, in our time frame, and things like that. I certainly care. There's not a lot of options we have for those people as far as long-term care, but we can certainly try. Excuse me. Um, Close collaboration with a psychiatrist and family physician. As I put this on here, I can't tell you the last time I saw a psychiatrist in the emergency department. Maybe I should, but it's just that ability, to have mental health professionals. We certainly want them to kind of screen and kind of get that person maybe into that. A lot of times, in talking to the family physician may say, "Yeah, I think we've got a problem here," that kind of stuff, but they can be very much against kind of confronting that person. It is most often dealt with by avoidance or pacification. I'm going to avoid the issue here and treat them and street them, as we say, or just pacify them. Okay, I'll give you whatever you need, whatever you want. They've got insurance, so they're not really complaining too much about it. I've seen both. Um, Confrontation needs to be done gently. And, sometimes I think instead of cornering somebody, I think if you might say something like to the effect of, I think we got a problem here. You seem to be coming in a lot for this, for these different things. Do you think maybe you need to go talk to somebody? Everything we've done, there's been nothing physically wrong with you. I understand you're scared. I understand, you have these illnesses, or you think you do, and maybe you need to talk to somebody, that kind of stuff. I've seen that work a little bit as far as follow up. I'm not really sure, but I've also seen it where patients just like throw a fit, or saying, so you're saying I'm faking this? I'm faking this? I'm not faking this, that kind of stuff. And that goes south really quick. I've also seen where people are like, okay, busted, I'm out of here. And not confrontational. They just leave. Sometimes they don't, as I said, even leave AMA. We've had patients in the hospital who we suspected Munchausen's, and just all of a sudden somebody goes back to the room and they're gone. Nobody signed out or anything. Referrals, if somebody's willing to kind of take this on, that would be great, either for somebody who is a mental health professional, and in concert, obviously, with somebody who is also able to medically screen them as well. So key points with this, I usually talk to nurses, so I do have nursing intuition on there, but just rely on your intuition. That gut feeling where you say something like, something isn't quite right with that lady. I don't know what it is. Or if you say, this story doesn't add up, things keep changing. If you're saying things like that, just again, is that another red flag? Like, we need to kind of be thinking about what's going on here, and I think there's more to the story, that kind of stuff. Big important thing: don't allow anger or hostility when you feel you're being deceived. As I told you, these patients have an intense and sometimes deadly need for sympathy and attention, and they love to get us in a perplexed state, as I mentioned before. So they spend their lives doing this. They really do. Where we take care of patients all the time. And so if a patient tricks you or whatever, it's like, yep, okay, we still erred in favor of the patient. Yeah, we got sucked into it. Yep, that's fine. Okay, move on next. And just don't, and obviously don't give somebody else a hard time about, she was faking all this stuff. Well, you know what? I don't know. I had a feeling, but I'm going to err in favor of the patient. And I think it's really important to kind of keep a professional, viewpoint of that, and keep that at the forefront as well. So if it's Munchausen by proxy, we do have a duty to report that any potential abuse or neglect. Abuse occurs much less frequently, but is easier to sort of report and diagnose. Neglect, again, not giving them the medication, or not filling it, things like that, or not taking care of them, occurs more often, a little harder to prove. Make sure your documentation is good. Again, being objective, that the behaviors or what you're seeing or what is being said versus judgments and things like that. I think that's kind of a good thing to kind of keep at the at the helm of this. So I would want you to be thinking about your stories, and you probably already have. I'll tell you just a couple brief ones that I encountered. One was I had a we had a patient at many years ago who had presentation like this with Munchausen's, cardiac presentation. This was before we were taking people to cath lab. She was in the ICU. Very dramatic, screaming nurse, this, I'm having this happen and all that. Very frustrating, very taxing for the staff. Just like, I'm having a heart attack. People don't care, like just going on and up and down in her room and everything. And every test was normal. And so the cardiac was referring her to GI was referring her to neuro. They also called in a psychiatrist to see her, who they usually don't come to the ICU. So anyway, we were like very frustrated with her, and we sometimes she'd just come out to the nurse's station and say something, and so we were sitting there trying to go over, like, here's a couple of things we got to do. Okay, number one, we got to talk to her about she can't be yelling out, just put your call light on. Like, we were going over a couple of things, and all of a sudden I looked up, and this lady is standing at the desk, and she goes, "You all are talking about me. I can't believe you're talking about me." And I said, she was kind of a tall, kind of heavy set lady. And I said, "Yes, we are." I said, "We're actually having a conference about you because we're trying to figure out how to treat you." And she goes, "You're having a conference about me?" And I said, "Yeah, we are. We're actually trying to figure out how we can best help you." And she goes, "Oh, you're having a conference about me?" And I said, "Yeah, we're meeting. We're kind of going over some things we want to do to help you." And she was like, "Oh my gosh. Oh, okay." She goes, "Well, do you want me to stay here, or do you want me to go back in my room?" And I'm just going with this. I'm like, "Well, why don't you go back in your room, and I'll bring the notes in, and I'll tell you what we went over." And she was like, "Oh, okay. I'll be in my room. I'll be in my room." she, I shouldn't be laughing, but I am. So she like goes back in the room, and like the ICU nurses I'm working with, they're like, "Oh my God, I cannot believe like she," but I was just honest with her. We're like, we're meeting to discuss this and stuff. And so anyway, so we came up with some things, who we were going to talk to, and social worker and all that kind of stuff. So by God, I wrote it all down. So I went in there and I said, "I'm going to make a copy of this." I said, and I had this piece of paper. I'm like, "You can't be screaming out. We have I don't, at the time, I think it was an 8-bed unit. We have people up here with this and that." And she was like, "You have people up here with like heart attacks and stuff." So with kind of, being careful what I said, I was like, "Oh yeah, we have somebody on a respirator. We have this." She was just thrilled that I was like letting her in on that. And so I made a copy of what we were doing, and the kind of things we wanted to do and that kind of stuff. She thought that was the neatest thing. Anybody that came in her room, she was like, "Now look at that. Listen, this is what they had a meeting about me, and this is what all the stuff I'm going to do." Like, how that worked out, I don't know. And she's in the ICU. And the very next day, we had a patient we were coding, and they were coding that patient, and a nurse came in and said, the bed 8's gone. And we saw her actually on camera, She walked outside. She wasn't on a hold. Walked outside with the sheet wrapped around her, and she picked up a vase of flowers that were at the desk and carried the flowers out and went outside, and we never saw her again. We called security and they were looking for her and stuff. And so that's how that one turned out. We did have I as I said, I published an article in a nursing journal. This is one of the sickest things I've heard in a while, but I had a person who called me. This was kind of before email and stuff, and it says at the when I wrote the article, it said where where obviously I worked at Sandy's and stuff, and I guess they called and I guess left a voicemail for me or something like that. So I called this number back from work, and the person left me a message and said, I have some experience with Munchausen's. I saw your article. I would like to talk to you about it. And this was before articles were online. And this person she was an EMT and she was in nursing school, is what she told me. I don't know what's true and what's not. And she was like, I have Munchausen syndrome myself, and I don't know if you're writing another article, if you would want to interview me or not. And I thought, what a bizarre thing. And I remember I was so glad I called her from work and not from my home number. And so I was talking to her. I finally had to hang up on her. She was saying like, yeah, like my favorite is to transfer a nursing home patient. And she said, you know how they have like their Foleys have like their massive UTIs and stuff like that. She said, I always have a syringe and I withdraw the urine from that Foley and then I keep that and then I inject it into my vein. And when she was telling me that, I was just like, I'm sorry, I can't talk to you anymore. It was so sick, and she wanted, I think again that she wanted me as an RN to like be, amazed by that or whatever and stuff. And I couldn't talk to her anymore and stuff. And she actually called me again, and obviously I didn't return her call. I do also remember very well a patient at the Old North in Covington who came in, classic presentation um, of 25 drug allergies. She said she was HIV positive, had 2 heart attacks, had COPD, was a brittle diabetic. I mean, just went down the list. And this girl was 30 years old. And so she had her presentation was cardiac. There was nothing wrong cardiac wise. We called her family doctor, who her family doctor did say to the ER physician, I'm pretty sure she's a Munchausen's. I talked to her about it a little bit, but I you know I just try to deal with her. And so the doc said to me, let's go in. I want to talk to her. And this doctor at times could be kind of a pain to work with, but I'll tell you, I'll never forget how nice he was to her. And he kind of said a little bit about what I said. He was like, I think there's a problem. Your every test we've done. I mean, she was there like, I don't know, 4 or 5 hours. Every test we've done is normal. Your vitals are normal. Your labs are normal, things like that. And, he was kind of like, do you think you need to talk to somebody else? That kind of stuff. And she got very, very upset and screaming and crying. And so, like, I'm dying and nobody cares about me or anything like that. And she's got her clothes on and stormed out. And so she didn't sign out AMA and stuff. And so probably about 30 minutes later, this is said at the North, they announced overhead, but would the nursing supervisor go to the cafeteria stat? Nursing supervisor go to the cafeteria stat, which was on the other side of where the emergency room was at the North. And just something told me she's in the cafeteria. And this was like maybe about 4 p.m. I was like, something just tells me that. And plus, if there's an emergency in the cafeteria, we're going to get them as a patient. So I went over there. I come around the corner and this girl is sitting in the cafeteria, sobbing, crying. And there's like 3 or 4 lunchroom ladies around her. And all of a sudden, this patient looked, she goes, "That's him. That's the guy that told me there's nothing wrong with me and I'm dying of a heart attack." Well, I thought these four lunchroom ladies were like going to kick my ass. They're like, "Terry, what are you doing?" She said, I'm like, hold on just a minute here. And they're like, "She's sick and we can't believe you didn't do anything for her and all this stuff. And what kind of place is this and everything?" And I'm like, I go, "Come on, we'll take you back, sort of divide and conquer. I'm like, let's take you back. I'll take you back to the emergency room, like I thought I was going to be ripped to shreds by the lunchroom ladies. And I'm like, hold on. It's okay. We'll take care of her and everything. And she was like, no, you're not taking me. You're not, whatever she was yelling. And she ran out the back door and stuff. And, again, I was trying to be respectful and say these ladies, I'm like, there's more to it. I think she's okay. I said, let me go call security, that kind of stuff. And so anyway, so I go back to the ER and I'm back in the ER and about a half hour later, they call down. She's in the chapel now at the North and one of our nuns from pastoral care is there. And I'm like, I'll go up, but I need a guard to go with me or something because I didn't know what this lady was going to accuse me of or whatever. So I go up, and one of our nuns, she was like, "Terry, how we are a Catholic facility," and this woman's just patient's just screaming and crying like he's been mean to me, and she was like, "This is not in concert with our beliefs, and we're Saint Elizabeth is built on this." And I'm like, oh my gosh, like this, I am mud at this hospital now and stuff. And the guard was kind of like, "Is this the lady we're looking for?" And I'm like, "Yeah." And so sister was like, "I can't believe we're treating somebody like this. We're Christians, we're Catholics." And so I'm like, "Sister, I'm sorry. Okay, we'll take her back to the emergency room." She was like, "I'm ashamed of how we've treated her and stuff." And so anyway, the guard and I were taking her back, and we were about halfway to the ER, and she bolted and ran out the door again. And I'm like, I don't know where she's going now, but I never heard from her again. So that's typical Munchausen's presentation. So thankfully, I did some damage control in the lunchroom. I was afraid to eat in the cafeteria for a couple weeks after that, though. But I did do some damage control with sister as well, and kind of pointed that out. So I think we're okay. But again, I think these stories are fascinating. They're sick at the same time and stuff, but I'm sure you may have some as well. So anyway, well, that's my contact information and stuff. But let's open it up, I guess. If Tony, if people have questions, I didn't really monitor the chat here while I was talking, but if you have any questions, comments, or anything, I'm glad to answer or help you out. If you're talking, Tony, I can't hear you.
Yep, we're all good. Does anybody have any questions? One of the questions in the chat, Terry. Have you seen people? Sorry, hold on once. Have you seen people moving into claiming PTSD when they can no longer claim physical illness, claiming that PTSD is now the cause of their physical symptoms? Long history of illnesses. Now docs don't believe or challenge their diagnosis, so the patient moves to a psychological disorder that causes the issues.
So the question is, have I seen that? Yes, I have. And again, in our limited exposure with that patient, to me, that's a difficult call to make, whether that's a legitimate problem or that or not. I do feel like in those situations, those patients really do need the assistance of a mental health therapist, because I don't think it's up to me to say, oh no, this isn't legit or not. In our model of delivery in the emergency department, to have that workup or things like that, we're limited in that ability to do. But we can certainly refer patients. And I think, again, a little gentleness, a little support, a little understanding, and say, maybe you need to talk to somebody about this. Even if you have legitimate serious illness, it has psychological ramifications with that as well. And so it's something where I think that person may need that support as well, and maybe their family does too, because it's not an easy thing to navigate. I feel sorry for people a lot of times who have a chronic illness and kind of get bounced back from doctor to doctor and lab tests and diagnostic tests, different areas. And I think to maybe offer them that support, I think is a good call. Hope that answered the question.
I'm looking to see if they've got any follow-up questions.
This chat.
Yeah. So Matt Lewis, I'm going to try to unmute you here. Like he has a question, but I can't. Matt, can you put your question in the chat if you've got one? I saw you raised your hand.
He might
Matt.
have access to his mic now.
Can you
There
hear
it
me?
is. Yeah, now we can hear you.
Gotcha. Yeah, is there a severe echo on your side?
So sorry, we're getting nothing but echo from you.
I'm glad you all hear that too. Okay.
Matt, can you type it in the chat, your question?
For some reason, I'm unable to use the chat feature.
Hold on, Matt. We're trying to figure it out here for you.
Have audio.
So I'm going to see if he's able to put it in. Matt, I'm still not sure if there's a way to get your question answered. Unable to use the chat feature, open my mic. Huh.
Matt, you can email me, terry.foster@stlisbeth.com. I'm happy to answer your question later or whatever, if that helps you out, buddy. Sorry about that. It's terry.foster@stlisbeth.com, or you can text me too. I think my contact info was on there for you.
Why his chat's not working? We'll work on getting Matt's question answered. Anybody else have any comments or questions for Terry? And if not, I've been posting a couple different things. Most hopefully you all can see the May 5th is the Tactical Tools for Thriving Annual First Responder Symposium. QR code on that if you want to register. As I've said before, our past presentations are available. If anybody's interested in reviewing any of the past ones, there's a QR for the YouTube page, and I'll get this one up hopefully by the end of the day. So if you want to go back and listen to this presentation or share it with your friends. There's a doctoral student that is doing a ambulance safety survey. Again, another QR code. If you take a moment to fill it out, he would certainly appreciate it. He's an EMT. And then this is our next presentation on May the 6th at 10 o'clock. It'll be pediatric abuse. Should be a good presentation, and I'll make sure that I add anything at the end to, if you do attend, I'll get you a pediatric abusive head trauma. And then our nursing conference is, EMS nursing conference is coming up October 9th. A QR code to save the date kind of thing, just puts it in your calendar. So if you're interested in any of those things coming up, go back. And then we have a website, and our newsletter, the handoff, is available on that website as well. So links to all these things should you have any interest in getting more education, contact with us for any type of specific training you guys want. And we're available as much as possible. And Terry, thanks again for your time. And with that, I will conclude today's class.
Okay. Thank you. Thanks for having me.
Like 34, 35 registered, right?
Mhm.
Sunday.